with today's class, which is on small malignant round cell embryonal tumors. To the diagnosis. When I'm saying that means we are just going to take a few examples and then discuss the morphology more than anything else, like more than even immunohistochemistry or molecular. So the clinical findings and the morphology, that is what is going to be the primary focus. Okay. So when I'm saying a malignant round cell tumor, by definition, these are sea of primitive or embryonal cells with little or no differentiation. And that means when you look at them, you don't know, you know it is a malignant tumor, definitely yes, but then you wouldn't know what lineage of malignant tumor that is. And it has, the chromatin is very immature and so-called embryonal. And that is a very, very basic morphology of so-called malignant round cell tumor. But having said that, these are heterogeneous group of tumors. There are a lot of varieties of the malignant round cell tumors that one can get. All of these tumors have their diverse genetic abnormalities. There are diverse clinical presentations and different kind of outcomes. These are my preliminary slides before I actually begin with the cases, and those I will ask the students to present. But I thought before I start with the cases, these are some basic facts that I should just be talking about. And I just said that there are different types of round cell tumors. Why should the pathologist actually make any efforts to differentiate one from another? The reason is very simple, is that they are treated differently. Treatment approaches of each of these tumors is very, very different. And we have Dr. Girish Chinnaswamy with us today. Maybe in between the cases or at the end of the talk or at both occasions, Dr. Girish will, he can just give his inputs about this approach or this aspect of the diagnosis as to why is this in first place important. All round cell tumors, for example, would look the same. And why do we have to go in depth? And why do we have to take so many efforts in terms of clinical reports, pathology, immunohistochemistry, sometimes molecular? Why do we even have to differentiate one from another? I think, Girish, I will leave this part to you. But at this moment, just take us just few examples. Neuroblastoma, for example, this is one round cell tumor which has a huge spectrum within itself. So the morphology and the biology of the entities which exist within this spectrum are very different from each other, and that will also impact on the management of this patient. On the other hand, if we diagnose a round cell tumor as rhabdomyosarcoma, the primary treatment is indeed chemotherapy, but radiotherapy and surgery are equally important. Even sarcoma, chemotherapy is the primary goal of, or the primary approach of treatment, whereas the radiotherapy is given to some selected patients, and also surgery is not performed in all the patients, and that is based upon treatment response. As you all know, lymphomas and leukemias are also round cell tumors, and they have their specific chemotherapy, which is very, very different than the other round cell tumors that you are seeing in this panel. So on and so forth. So we have numerous round cell tumors which need to be distinguished from one another for the purpose of management of each of the patients. How do we approach this? What is the diagnostic process? There are 4 diagnostic pillars. One is the clinical, radiological, and biochemical parameters. We have to start with these inputs. Without that, you cannot just go ahead. And I'll just in a minute, I'll tell you how only this first step can help us arrive at the diagnosis in a vast majority of cases. The second is basic morphology. We histopathologists, we are the morphologists. Our eyes and brain are trained to interpret the morphology that we see under the microscope, and that forms the basis of our differential diagnosis, that forms the basis of deciding which immunohistochemistry has to be done, and that also helps us to decide if molecular testing is indicated or not, and if indicated, which one. So these are the 4 diagnostic pillars of differentiating malignant round cell tumors from each other. Okay. Now coming to important clinical determinants. There are 3 important clinical determinants, out of which the first 2 are extremely important, and that is age of the patient. Is the patient a child or the adult? And if the patient is a child, what is the age of the child? Is it less than 3, more than 3? Then site, a specific organ. Just a round cell tumor occurring in a specific organ in itself gives away the diagnosis in so many cases. If it is arising in the bone, is it arising in the soft tissue? If it is not in any other specific organ, and what is the radiology? And also biochemistry is helpful in certain tumors, like raised urinary DMA levels in neuroblastoma, serum alpha fetoprotein levels in hepatoblastoma, and so on. So age and site. Never forget to start your diagnostic process with these 2 elements. Even before you see the slide, you should have this information at hand. And if it's a child, as I said, the patient's age, child versus adult. So what I mean is that the round cell tumors also occur in adulthood. And what I also mean is that when it is the child who is suffering from a round cell tumor, the age of the tumor also impacts our differential diagnosis. So if you are armed with this information, our list of differential diagnosis is ready in our brain, and see how it impacts. If the child is less than 3 years of age, neuroblastoma and the lymphomas and the leukemias are the top on my differential diagnosis list, followed by Wilms tumor, retinoblastoma, rhabdomyosarcoma. On the other hand, if this child is more than 3 years of age, then the differential diagnosis of neuroblastoma shifts a little bit down into the list, and then the other differential diagnosis like Ewing sarcoma, peanuts, rhabdomyosarcoma, lymphomas, leukemias are still they are still in the list of differential diagnosis. So they are the important. So age is impacting the differential diagnosis quite significantly. If it is not an organ-specific round cell tumor, if the bone is involved, if the child is more than 3 years, as I just said, think about Ewing sarcoma, think about small cell osteosarcoma, mesenchymal chondro, lymphoma, and leukemia. If the patient is less than 3 years, then think about metastatic neuroblastoma, leukemia, lymphoma. And if it is in the extremities, think about rhabdomyosarcoma and Ewing sarcoma. It is so easy when it becomes an organ-specific tumor. Okay, so if a round cell tumor is occurring in an adrenal, what will you think about? Will you think too much beyond the neuroblastoma in a particular given age? You will not, and you should not as well, unless the clinical and morphological parameters are way beyond the morphologic spectrum of neuroblastoma. Similarly, a round cell tumor occurring in the liver, is it wise to think too much beyond hepatoblastoma? No, that should be your first thought. Similarly, in the eye, retinoblastoma, kidney, Wilms tumor, bladder, rhabdomyosarcoma, if they are peritoneal masses, desmoplastic small round cell tumor. So, an organ-specific small round cell tumor becomes an easier situation for us to enlist differential diagnosis, and also to decide what is the next plan of action for our diagnosis. So far, what we just talked about is accurate diagnosis is crucial. The reasons behind that, because there are different approaches to therapy for distinct tumor types, and then within a given group of tumors, therapy is also tailored according to the patient's risk stratification. This is what we just spoke about. And as I said, the round cell tumors do occur in adults as well. And when we are thinking about about them, think about lymphomas, think about small cell neuroendocrine carcinomas, alveolar rhabdomyoid sarcomas, melanomas can show small round cell morphologies, and subtle carcinomas can mimic malignant round cells. And if you're not aware of it, it is a big pitfall. Prostatic carcinoma, small cell variant of hepatocellular carcinoma, and a few more as well. Now we should begin with the case. And when I am beginning with the case, this is a prototypical malignant round cell tumor. We spoke all about the huge list of differential diagnosis. I talked about which tumors occur in which age, which organ, and the impact of age or everything else. But what do you think is the most important step in the diagnosis of a round cell tumor? Can any of the 5 students answer this question?
Yes, ma'am.
Before we start with our cases, the most important step in the diagnosis of malignant round cell tumor. Who can take this question?
I think one of the most important differential diagnoses you think about when you receive a small round cell tumor should be a lymphoma.
Should be a lymphoma. Okay.
Lymphoblastic lymphoma.
I'm not talking about this case in particular. This picture is just displayed to show you a prototype of a round cell tumor. But listen to my question carefully. I'm asking you, what is the first critical step in the diagnosis of a malignant round cell tumor? Rajesh, can you take this? I mean, anybody. It's not for any specific person. Anybody.
You're speaking like microscopic.
Yes. So you have the history with you. For example, it is a child, and you have a morphology. Just in this instance, look at this image. Okay,
Actually,
this image.
it's showing sheets of monomorphic cells of round cells.
Yeah.
These round cells have high NC ratio.
Why are you saying that it is a round cell tumor?
Because this is all the cells look quite uniform in size and shape.
Okay.
It's almost the nucleus is round to ovoid in shape.
Right.
And it has a very scant cytoplasm, which is very characteristic of small cells. And at some places it's showing nuclear molding as well, with a prominent nuclear line.
What? Molding. Okay, I can't see molding. But yes, so the point I'm driving at is, my question was, what is the most important step in the diagnosis of malignant round cell tumor is to recognize that it is a malignant round cell tumor. Okay, and I will just make this point very clear in some of our cases that we are going to discuss next. The reason being that, although we are looking at a very prototypical malignant round cell tumor, as Rajesh has correctly described, here each cell is similar to the one which is lying next door to it. So the cells are pretty monomorphous. Each cell is looking similar to its neighbor. The cells have embryonal cytoplasm and there is, the chromatin, and there is very little cytoplasm. There are some apoptotic bodies, and this is like a sea of cells with embryonal features. Extremely primitive, undifferentiated cells. Absolutely no signs of differentiation in any way. Okay, and this is a prototype of a small round cell tumor. So the first step is to recognize that a given tumor that you're looking at under the microscope is indeed a round cell tumor. If you miss this important point at the first phase, you will be taken down the garden path, because you will miss that very first important diagnostic clue, which is entirely based upon your morphology, also based on your clinical endpoints. So everybody agrees that the image that we are looking at is a round cell tumor? Yes, we do. Now we have a 10-year-old patient, and this is a mediastinal mass. What are the possibilities? As I said, organ specific tumors. If it was an adrenal, what should have been your thought?
Neuroblastoma.
Neuroblastoma. If I said this was an eye tumor, I would think about retinoblastoma. Of course, undifferentiated. But now this is a 10-year-old with mediastinal mass. So just tell me, what is your thought process? Is it neuroblastoma? Is it retinoblastoma? Is it hepatoblastoma?
It can be neuroblastoma.
It can be neuroblastoma. Okay. And what determines that thought here?
Because it arises in a sympathetic neural tissue, sympathetic neural chain, wherever the sympathetic neural chain is present.
Right. So any other thought in this case? So Rajesh thinks it's a neuroblastoma. Anybody contesting this diagnosis or any other additional differential diagnosis? Anybody doubting that
It can be lymphoblastic lymphoma.
The
primary lymphoblastic lymphoma. Okay, so don't you want to know anything more when you're talking about these two differentials, neuroblastoma, lymphoma? Don't you want to ask which mediastinum this lies in?
Yes, ma'am.
You do? Okay, and why? Why do you want to know?
Because in anterior, mostly if the mass is anteriorly in the anterior mediastinum, it would be lymphoma or teratoma, thymoma, and usually neuroblastoma we will find in the posterior mediastinum.
Correct. That's very right. So Rajesh, before you said neuroblastoma, you should have asked me, where did this tumor, which part of mediastinum did it lie? Okay. That will, again, of course, you will think about both the possibilities, but then if there is more clarity in your mind as to the exact clinical presentation, the precise radiology, and here is when you should talk to your radiology colleague as to, you should ask the question, tell me which mediastinal compartment does this tumor lie into. In fact, I did not want to spend a lot of time on this case, but I wanted to drive a point across that the first step is to recognize that it is a round cell tumor. Okay. And this is a prototypical round cell tumor. In this case, this was inherently lymphoblastic lymphoma, right? So with this classical image in our mind, we should move further. Okay, now this is a case number 2. So we can take case number 2 and 3 by one single person. Who is ready to take this? Is Diksha there?
Yes, ma'am.
Kenny?
Yes,
Yes,
ma'am.
So you do case 2 and 3. Okay, we'll take them together.
Ma'am,
So this is a 6-year-old child. Biopsy
Yes,
of a bladder mass is done. And
Yes,
this is what it is looking like.
Yes, ma'am. So the first image shows a section showing a polypoidal structure lined by stratified epithelium, and subepithelial region shows accumulation of dense accumulation of small round cells, which is undifferentiated. Probably it is the cambium layer, and there is also loose myxoid matrix in which small round cells are dispersed. In the The second image, I can see myxoid. I can see small, in one region, I can see epithelial lining, and
Yes.
the rest of the region shows small round cells as well as a few ciliate-shaped cells, elongated spindle-shaped cells, dispersed within a myxoid matrix.
Okay.
And the nuclei of the cells are showing hyperchromasia with very little cytoplasm. My differential diagnosis for this case will be botryoid variant of
Wait. I just wait. Henny, can you just wait?
Yes, ma'am.
It was Henny who said it was a round cell tumor.
Yes, ma'am.
Who is agreeing with Henny and who is disagreeing with Henny? I am disagreeing with her. I mean, look at this image that we just saw, which we said was prototypical round cell tumor. And do you agree? These are small round cells.
They are round to irregular shaped cells, ma'am.
Now you have come to round to irregular. Okay. What is dominant cell shape here? It is more spindly, isn't it? It's not really that prototypical round embryonal cell. Okay, the shape of the cell is more spindly, and some of the cells do have some cytoplasm. Not all of them are devoid of or have scanty cytoplasm. But what is most important thing to notice is the chromatin. Okay, the chromatin is embryonal. It's extremely primitive. Okay, the cells are hyperchromatic, but they are not prototypical round cells. And as you correctly described the other features, that there is some condensation which is just immediately beneath the urothelium. Then the matrix is myxoid. But the point I want to make here is that these are malignant cells, no doubt about them. They are primitive embryonal malignant cells which are in the bladder, but they are not prototypical round cells. They are more of a stellate shaped cells. Some are spindly. They have irregular nuclei, not those round cells. Okay, so we are here talking about the variations on the theme of the so-called round cell tumor that is possible, which you should always recognize. Otherwise, there would be a mistake in the diagnosis. Now, can you tell me what are your differential diagnoses here?
So, ma'am, my diagnosis is embryonal rhabdomyosarcoma, botryoid type. I agree with her.
Right. Now, what would you do? Any differential diagnosis? Anything?
Plastic round cell.
In the bladder? Anyway, let's move on. So, what would you do? What is the next step?
IHs.
IHCs? Do you think IHCs are mandatory in the diagnosis of malignant round cell tumors?
No, ma'am.
No? So, will you call this embryonal rhabdomyosarcoma and sign it out? And can the patient start with treatment?
Yes, ma'am.
Yes?
Yes, ma'am.
No, I completely disagree with you. If you are thinking this is a case where there are bladder masses, definitely bladder masses, clinically it is like embryonal rhabdomyosarcoma. We are seeing features which are of primitive cells which are stellate, some are round, but then immunohistochemistry is mandatory to determine the lineage of these cells. It is absolutely mandatory in all malignant round cell tumors. And which one would you do?
Ma'am,
You are
I
thinking
went
of
Myogenin.
testing.
Vimentin? Who said Vimentin?
Myogenin.
Myogenin? Yes.
Myogenin.
Desmin, then
You are
myogenin.
thinking of rhabdomyosarcoma, which is the basic immunohistochemistry strain that you should be starting with.
Desmin and myogenin.
Muscle
Desmin.
specific.
Yeah. So desmin is what is desmin? They are the cytoplasmic filaments which are expression of muscle differentiation. And when it comes to specific skeletal muscle differentiation, what will you do? Myodecan and myogenin. Yeah, agree? Okay. So let's move on. So this is the desmin as we have asked for. And what do you see here? Is it positive or negative? This is the overlying urothelium, and these are tumor cells. And look at their shapes again. They are even more highlighted with immunohistochemistry. How spindly they are, how stellate they are. There are very few which are really nicely prototypical round cells. So is this desmin positive or negative?
Ma'am,
It
positive.
appears to be Desmin positive.
Desmin positive. There is strong and
Positive.
brown staining in the cytoplasm of tumor cells, and you can see the nuclei which are blue staining, which are pregnant, they are negative, right? Great. Okay. So this was an embryonal rhabdomyosarcoma. So these tumor cells were also myoD1 positive. I don't think I did a myogenin here. So this was embryonal rhabdomyosarcoma. Agree? Fine. So let us move ahead. This is another case, case 3. Now, this time it is a 14-year-old boy with a mass in the nose. Can you describe this tumor? It's a nasal mass.
First, scanner view magnification shows sheets of small blue round cells separated by thick fibrovascular septum. No rosette seen. Second image shows sheets of small blue round cells. Cells are small to medium in size, having round-shaped hyperchromatic nuclei and a scanty amount of eosinophilic cytoplasm. Few multinucleated giant cells also seen, and a few ganglion-like cells seen. Third image shows the alveolar arrangements of the small blue round cells, having they are small to medium in size and having round-shaped hyperchromatic nuclei and scanty amount of cytoplasm.
Okay. Okay. So anybody wants to add anything more to this, or do you disagree with some of the findings? First and the foremost is, do we all agree that this is a round cell tumor?
Yes.
Okay, so that is one great step that we are taking ahead. So these cells, I think it is best seen in this panel. I wish I had a higher magnification of this image, but the cells are monomorphic. The one cell is like another cell, like how we saw in the lymphoma slide. But this time there is some pattern that is coming in because of this fibrous septae here. It was correctly said that there are some blood vessels, some fibrous septae. And then what are these cells? You said these were ganglion-like cells. Are they ganglion cells? What are they? They are multinucleate giant cells. But they're not ganglion cells. Not ganglion cells. And what is the other finding that you are seeing here in this image?
Third image is alveolar arrangement of cells.
Alveolar arrangement. Okay, now what do you mean by that exactly? What do alveoli mean? Where do you see alveoli normally? Sorry.
Lungs.
Where do you, in the lungs, yeah, in the lungs. So the alveoli are very nice, well-defined spaces, and they're lined by what which cells?
Complete life.
Huh?
Pneumocytes.
Okay, pneumocytes. Now here, do you see that these are well-defined spaces? Yes, like the lung alveoli.
Yes, ma'am.
They are not really well-defined spaces. These are actually the artifacts which are formed because of the cell dissociation from each other. Okay, so if you want to call it, these are actually the pseudo-alveoli. These are not the true alveoli that you see in the body, like for example in the lung. So what is your differential diagnosis here? Now the age of the patient is 14-year-old. The site is nasal mass, and this is the morphology. You do have a round cell tumor at hand, which has some pattern. There are some multinucleate giant cells, and then there are these alveolar spaces. What is your differential diagnosis?
Ma'am, alveolar rhabdomyosarcoma or olfactory neuroblastoma.
Okay, yes, very good. Good differential diagnosis. Anything else?
It can be sinonasal melanoma.
Melanoma in a 14-year-old?
Okay.
No, don't think about that too much.
Undifferentiated.
Head and neck is one site. Why I wanted to take this case was head and neck is one site where a whole lot of differential diagnosis comes in any form of the tumor, and especially in a malignant round cell tumor. If you can have so many entities that can be malignant round cells, and you should be aware of all those round cell tumors which can exist there. But here we have certain very important morphologic clues, like there is a certain pattern. The cells are in nesting pattern because of this fibrovascular stroma, but that may or may not be there. It's not a classical feature. You have alveolar arrangement or pseudo-alveolar arrangement. You have multinuclear giant cells. So it points towards what? More towards alveolar rhabdomyosarcoma. Yeah. Okay. What immunohistochemistry would you ask for?
Desmin,
Desmin,
myodibin.
Yes. Okay. So this tumor was indeed
Reason.
desmin positive and myogenin positive. Okay. So
Peak
this was
adherent.
alveolar. Sorry.
Peak adhering.
E-cadherin. What for? What is E-cadherin for?
Peak adhering for alveolar rhabdomyosarcoma.
Is that a diagnostic marker?
No.
No, absolutely not. You will not. If you are thinking of alveolar rhabdomyosarcoma, the first thing that you would ask for are the muscle-specific markers. The first is desmin, followed by myodin and myogenin. If you have both, if you have the capacity to do both, do both to them. And what is more important is also to add other differential diagnosis into the panel of immunohistochemistry. Okay, just adding desmin or myogenin and myodin in the head neck site is not adequate, and we will come to that some time later. But here at this point of time, we are focusing on the morphology of how the embryonal rhabdomyosarcoma look like and how alveolar rhabdomyosarcoma look like. So although both were rhabdomyosarcomas, both were different. Right? So one was spindle cell tumor, another was a prototypical round cell tumor, but with very specific morphologic indicators of alveolar category. So the third, next case 4 is, this is a 4-year-old child with a thigh mass. Who can describe this?
Ma'am, it is the image shows sheets of small blue round cells. They are small to medium in size, having round to oval shaped hyperchromatic nuclei and scanty amount of eosinophilic cytoplasm. Few ill-defined rosettes are also seen, and a few mitosis also noted. The background shows focal loose myxoid appearance.
Okay, I don't really agree with some of your descriptive points. Can anyone chip in anything that this tumor is showing which is not said?
Eccentrically placed nucleus and prominent nuclear also.
Eccentrically placed nuclei.
And
So when you
prominent
say
nucleus.
eccentrically placed, that also means what? That the cells do have a considerable amount of cytoplasm, isn't it?
Yes, ma'am.
Yes. So when I'm saying that, are we again not deviating from that very definition we made of round cell tumors, where we said that the nuclei are monomorphous and there is scant cytoplasm? That is how we defined a malignant round cell tumor. Did we not? Yeah. And here we agree it is a round cell tumor because the nuclei are extremely primitive chromatin, hyperchromasia. But is it really monomorphous? Are each cell one cell looking like another?
Light and dark zone.
Some cells are big, some are small. They do have eosinophilic cytoplasm, and I really didn't agree with the myxoid stroma. I didn't see any stroma, and these are not rosettes actually. If you want, you can also call it the pseudo-alveolar spaces as we just saw earlier in the earlier case, but these are not rosettes. Rosettes are very well-defined structures. So if you want, you can call this maybe a pseudo-alveolar space. But again, see the pointers which are deviating from a prototypical round cell tumor. But yet this is an embryonal malignant tumor. Okay, so you must be realizing by now why should we even call them malignant round cell tumors? You know, as I always feel it is a misnomer. I feel primitive embryonal tumors is a better terminology when we talk about these tumors because there is so much of morphologic deviation. But any which way, it is ingrained in our practice. We perfectly well know what it means by malignant round cell tumor when we talk about it. But it is important to recognize these deviations because you will miss the very diagnosis of that round cell tumor. Now, in a 4-year-old, a tumor looking like this, around malignant round cell tumor, what is your next step? What is the differential diagnosis?
Embryonal rhabdomyosarcoma.
Sorry, which one?
Embryonal rhabdomyosarcoma.
Embryonal rhabdomyosarcoma. Now, why did you say rhabdomyosarcoma as your first differential? Forget about embryonal or alveolar.
Ma'am,
You are right. You are right. Why did you say that?
Well, sometimes in embryonal rhabdomyosarcoma.
Sorry?
Sometimes in embryonal rhabdomyosarcoma, it shows eosinophilic cytoplasm in the central nuclei. Some cells show higher level of differentiation.
Yeah, can you speak up, please? I cannot hear you properly.
Some cells shows in embryonal rhabdomyosarcoma, some cells shows higher level of differentiation and increase eosinophilic cytoplasm in the central nuclei.
Yes, so you are right. You are right that the rhabdomyoblast, even malignant rhabdomyoblast would produce a lot of cytoplasmic filaments in the form of desmin. Okay, so you will definitely see, this is the reason why we are seeing this eosinophilic cytoplasm. And one more feature about rhabdomyosarcoma is that you would definitely see this polymorphous morphology. Some nuclei are round, some are big. Just a second, just excuse me. Excuse me for a minute, okay? Just a second.
Till Mukta comes, I'll just like to comment on a couple of points. So the first case, which is about that there was actually a mediastinal mass with round cell tumor. Other than the fact that you actually ask whether it's an anterior mediastinum or a posterior mediastinum. So the superior anterior mediastinum can be lymphomas, most commonly in children, and the posterior mediastinum, as we discussed, was neuroblastoma. But in that situation, you should also ask additional questions, and it would be good to know that whether there is any evidence of SVC obstruction, superior vena cava obstruction, or superior mediastinal syndrome. Because if that has occurred, then you're almost always dealing with the lymphoma, and a neuroblastoma would not do that. So asking clinical questions to your clinician would be very useful for you as well. And as pathologists, do not limit yourself to just in the lab, and you're all clinicians as well. So it has to be a constant dialogue between the clinician and pathologist. The second thing is, if they happen to contact you before the biopsy, telling that we are actually going to do a biopsy for an anterior or a superior mediastinum, ask them two questions: whether they looked at the blood count and whether there is any blast in the blood count, because that would give a diagnosis on the peripheral blood itself rather than do a biopsy, which is a risky procedure in an anterior mediastinum when somebody has got a superior vena cava obstruction or there's an airway compromise. Second thing is, ask them if there's any pleural effusion, because if there is a pleural effusion, you could actually tap the effusion and do flow cytometry on that. So if they're going to do an anterior or superior mediastinal emergency biopsy, ask them these two questions. The clinician should evaluate, but you should also evaluate, because ultimately we're all treating the patient together, and so the safety of the child, the patient becomes very critical. So Mukta is back, and we can continue.
Yeah, thank you, Girish. That was so valuable. So never forget the entire clinical picture. So coming back to our morphologic nuances, so these cells do have this eosinophilic cytoplasm, and then these cells are not very monomorphous. Okay, some nuclei are big, some are convoluted, some are really, some have nucleoli, and so this is one clue as to this is not a lymphoma, this is not a Ewing sarcoma, and this tumor is in the thigh, so this is more likely to be a rhabdomyosarcoma. So these are the morphologic differential diagnosis that you would think about based upon the morphology, and this is strong desmin positivity and myodebin positivity. And myodebin is a nuclear protein which helps in differentiating the particular cell towards skeletal muscle. So it is expressed as against desmin, it is expressed within the nucleus, and that helps you to make the diagnosis of rhabdomyosarcoma. But as against these earlier two cases, wherein this case alveolar pattern was very well evident, and this case, which was a bladder tumor with nice spindly stellate shaped cells, desmin positive, which was a typical matured embryonal rhabdomyosarcoma. In this case, can you point towards whether this is an embryonal or an alveolar rhabdomyosarcoma? Can you do that? If you want to put your, which one do you put on?
Solid variant of alveolar rhabdomyosarcoma.
Okay. In fact, there are some pseudo-alveolar spaces here. So if I want to put my money on, I would put it on the alveolar rhabdomyosarcoma variant. The question is, should Dr. Girish accept my bet? And is it adequate for me to diagnose alveolar or embryonal rhabdomyosarcoma based upon this kind of morphology? And obviously, we will discuss the next point is, why should we even do that? Why is it important to distinguish between the embryonal RMS and alveolar RMS? So my question to you is, based on this morphology, how many of you are very, very sure that this is alveolar rhabdo and it should be considered so? As against, how many of you think it's embryonal, and how many cannot decide? And what would you do next? I don't want to lose my money here on a bet. I would say I cannot decide. Who is with me? Pleomorphic rhabdomyosarcoma, it doesn't happen at the age of 4 years. It is a tumor of elderly, and it is the tumor cells are highly bizarre pleomorphic cells, like any other pleomorphic sarcoma. It will not come into a diagnosis of malignant round cell tumor. And when I said pleomorphism, that is not what I meant. What I meant was, as against the prototypical lymphoma that we just saw, there is a difference in the nuclear sizes and the shapes. Although it is the same cell type all over, the cells are not like a C or not a a monomorphous cell population all throughout. And I never meant the pleomorphism that is implied in a pleomorphic sarcoma. These are very fine morphologic nuances which you need to learn when you are differentiating one round cell tumor from another, taking into consideration the clinical picture. So A or E, or cannot decide. Who are with me? I can't decide. I cannot decide. What do I do?
Immunohistochemistry and molecular.
Can immunohistochemistry differentiate between alveolar and embryonal variant? No, it cannot.
Multinuclear
Cannot
tumor
function.
giant cells.
They are not there. The entire tumor is this way.
Molecular studies.
Molecular studies, and which ones?
Alveolar will show PAX3 FOXO1 and PAX7 FOXO1 positive, and embryonal will be negative.
Okay, very good. That is excellent. So in this case, I will definitely ask for molecular diagnosis or that to distinguish between alveolar and embryonal. I would definitely ask for molecular testing in this case, because although I am indeed seeing some dissociation here in the form of pseudo-alveolar formations, I'm still not 100% sure. Okay, and that distinction is very, very important clinically. And here in this case, as against those earlier two cases, I will ask Dr. Girish to further the molecular testings to make a categorical distinction between alveolar and embryonal rhabdomyosarcoma. And the reason is that alveolar rhabdomyosarcoma is biologically more aggressive than the embryonal rhabdomyosarcoma. And within the subgroup of alveolar rhabdomyosarcoma, the PAX3 and FOXO1 positive ARMSs are worse than the PAX7 FOXO1. So it is not just the molecular testing, but also to see which type of translocation we are dealing with in the given alveolar rhabdomyosarcoma. Okay, so the prognosis of translocation negative rhabdomyosarcoma is equivalent to embryonal rhabdomyosarcoma. Now, the presence of the translocation is clinically more relevant than the actual histologic subtype of E and A. We would obviously try to do that in all cases of rhabdomyosarcomas, but it is best that the rhabdomyosarcomas are subjected to molecular testing for categorical distinction. Now, I am going to confuse you a little more, but I think it is important to drive this point across as well. As I said, endocrine rhabdomyosarcoma has stellate-shaped cells. Now, I'm going to show you a few more variants of rhabdomyosarcoma, which are completely dissimilar to the prototypical malignant round cell tumors that we just spoke about. This is one variant which is called as spindle cell rhabdomyosarcoma. This variant actually has cells which are spindly. They can look actually very, very bland. And unless we think about spindle cell RMS, and if we are not aware of this variant of rhabdomyosarcoma, we will miss the diagnosis. Similarly, anaplastic variants of rhabdomyosarcomas, they are more commonly embryonal, but anaplastic variants also exist in alveolar rhabdomyosarcoma. So if we are again looking at these cells, if we say that, oh, this doesn't look like a round cell tumor that I have read in the books or as I was taught, this looks like any other, and this is what a pleomorphic sarcoma would look like. I just said, somebody said pleomorphic RMS. So this is that kind of pleomorphism. And in a child, this is anaplastic rhabdomyosarcoma, and this diagnosis in itself has some different implications in terms of not only prognosis, but a possibility of it being a familial or a hereditary rhabdomyosarcoma or part of some syndrome. So it is important for us to recognize that a given entity, for example, a rhabdomyosarcoma in this case, may not show a prototypical round cell morphology, and it can have a lot of variants. Okay. And this is one embryonal rhabdomyosarcoma. It is maybe at a different site. I do not remember. This is showing something peculiar. What is it? This is also showing this spindle cell here, as we saw in the bladder, but it is also showing so many cells which are showing eosinophilic cytoplasm. And what is this? These are rhabdomyoblasts showing rhabdomyoblastic differentiation. Okay. And one more very peculiar thing I want to tell you all at this point of time is that rhabdomyosarcoma, although the name is rhabdomyosarcoma, but a rhabdomyosarcoma which is not treated very, very rarely displays any rhabdomyoblastic differentiation. You really have to hunt for it if you do not have immunohistochemistry and you are wanting to demonstrate that this is a rhabdomyoblast or a strap cell. It can be so difficult in a tumor which is not treated. But a patient who is treated with chemotherapy, suddenly the rhabdomyoblastic differentiation becomes so striking that all these cells, see all these cells have started to demonstrate eosinophilic cytoplasm, and they all are looking like rhabdomyoblasts. This is what is such a familiar picture that we have of rhabdomyoblast, but this appears more pronounced in a more pronounced manner in post-chemotherapy. Okay, so this is the ERMS with rhabdoid morphology, and this is a post-chemotherapy rhabdomyosarcoma. So that is rather unfortunate when it comes to the diagnostic process that we are dealing with. This is a higher magnification of a spindle cell rhabdomyosarcoma, strongly desmin positive, anaplastic rhabdomyosarcoma. Right. So now next, let's move to okay, we don't have much time. Let's move to case number 5.
Mukta,
This is
should
a 1-year-old.
I just give
Yes,
a minute or two
yes,
about why this is important clinically?
Yeah.
So I think so just to give the clinical perspective, why it is important for us to know that this is embryonal or alveolar rhabdomyosarcoma is because when we risk stratify rhabdomyosarcoma, we use 3 factors. One is the stage of the disease, the amount of surgical resection, and the third is the pathology. So conventionally, these 3 factors were used, and an alveolar rhabdomyosarcoma was never a low risk. So you have low, intermediate, and high risk, and an alveolar rhabdomyosarcoma was never a low risk. It was always an intermediate and high risk. And an embryonal rhabdomyosarcoma could be all 3. So could be intermediate, could be high risk. We don't have to go in more details of that. And how does it matter to tell this? An alveolar rhabdomyosarcoma always requires radiotherapy, whereas an embryonal rhabdomyosarcoma, which actually was fully excised and low risk, we can get away without it. So remember that in rhabdomyosarcoma, all rhabdomyosarcoma require chemo, most require radiotherapy, and only some of them will need surgery. So most require radiotherapy is only a situation where you don't give is an embryo which is fully excised and it's non-metastatic. Now over a period of time, it became clear that as more and more molecular biology studies were done in rhabdomyosarcoma, that there were a subset of alveolar rhabdomyosarcoma who were PAX3, PAX7, FTHR negative, actually did as good as an embryonal rhabdomyosarcoma. And similarly, a smaller proportion of embryonal rhabdomyosarcoma, which probably through sampling issues were called as embryonal rhabdomyosarcoma, but if they had PAX3, PAX7, FTHR positive, they behaved aggressively like an alveolar rhabdomyosarcoma. So for that reason, present classifications do not call them as alveolar and embryonal rhabdomyosarcoma. We stratify them based on fusion positive or fusion negative rhabdomyosarcoma. The fusion positive is the previous alveolar RMS, and the fusion negative is the previous embryonal RMS. So that's why it's critical, because the prognosis changes, the type of treatment changes. Now, just to give our own experience, when we actually looked at all the low risk rhabdomyosarcoma on morphology, and when we added molecular to that, 20% of the low risk became intermediate risk. So that means it's a very critical factor nowadays to actually do molecular testing, because the treatment would fully change if they were fusion positive. So I think that's the why you need to know, and you must make it a practice to actually do it in all RMSs, at least wherever the facilities are available, you should do that. I think that's all.
Okay, great. Thank you. That was a very important point. Thank you. So now let's move to our next class of tumors. This is an infant, a 1-year-old male child who presented with abdominal mass. And on imaging, there was a huge mass which was in the suprarenal region. You got it? Is the imaging very clear? These are kidneys, and there is a huge mass in the superior kidney. And this is how it looked like. Now, who can take these cases? Volunteers?
Ma'am, I can explain. Ma'am, I can.
And you are? Sorry, what's your name? Henny. Oh, okay. Henny, yes. Carry on.
This section shows islands and a nest of small blue round cells, which are separated by thick fibrovascular septa. Individual cells are small round cells having round-shaped hyperchromatic nuclei and scanty amount of cytoplasm. And ma'am, few homoryte pseudo-rosettes are seen with centrally pleased neuropil.
Okay. So why is this a round cell tumor? This is a suprarenal. This is a suprarenal mass.
Yes, sir.
Okay. So first of all, why is this a round cell tumor?
It is monotonous population seen. Cells are round.
Yes. Very scanty cytoplasm, and then there are presence of rosettes. And these, which rosettes are these? True rosettes, false rosettes?
Pseudo rosettes.
And why is that? Why are they pseudo rosettes?
Imbril are in center of fibrosis. Yeah.
What is this pink material in between?
Neuropil.
How do you decide it's a neuropil? Why is this not fibrosis?
Fibrillary processes.
Yeah, you can actually see fibrillary processes. There are some spaces in between, and if it was fibrosis, it would have been very dense and high-lying. Okay, so this is a neuroglial material, which is surrounded by cells which are small, round, with primitive chromatin. Okay, and so this is a tumor which is located in the suprarenal region and which is forming rosettes. And because of the neuroglial material, this is a tumor with neural differentiation. Now, what are your differential diagnosis?
Neuroblastoma.
Neuroblastoma, because it is showing neural rosettes. Okay, so that is quite correct. So this is a prototype of a neuroblastoma which is showing a good differentiation because of the presence of neuroglial tissue. So a tumor which is located away from CNS, okay, let us say non-CNS tumors which are showing neuroglial or neural rosettes. There are very few tumors which do that in the peripheral location. Can you enumerate any other tumor which does that apart from neuroblastoma? Sorry?
Retinoblastoma.
Yeah, retinoblastoma, yes. And sorry?
Ewing sarcoma.
Ewing sarcoma, Wilms tumor.
Ewing
Yes,
sarcoma.
agree.
Wilms tumor.
Wilms tumor, does it show neuroglial tissue?
Last tumor.
Sorry?
Thomas tumor.
Glomus. Glomus tumor does not show neuroglial rosettes. So when it comes to the peripheral location apart from CNS, I agree. Retinoblastoma, Ewing sarcoma, neuroblastoma, they will show neural differentiation. And one more tumor which will show this is an immature teratoma, which is showing glial differentiation. That can show this kind of morphology. And remember, Ewing sarcoma it doesn't always show rosettes. Okay, sometimes it does, but it is not a predominant morphology. So it is an easy diagnosis in this case. Do you require any immunohistochemistry here? 1-year-old suprarenal mass looking like this, a round cell tumor forming pseudo rosettes. I told you in the bladder tumor that yes, you would require IFCs in all malignant round cell tumors. I said that only some time ago, and I'm telling you something different in this case. Do you require immunohistochemistry for this diagnosis? Any?
Yes, ma'am.
Yes. Which immunohistochemistry do you require, and what would you establish from the IFC?
S100, NB84.
Promo.
NSC.
Okay, now just this whole image. For example, this was a very tiny biopsy tissue core that you had. Would you want to spare the tissue for immunohistochemistry? No, the answer is that in a prototypical neuroblastoma, in a conventional clinical situation like this one, we will not waste our tissue doing immunohistochemistry. This morphology in the clinical context is most adequate for the categorical diagnosis of neuroblastoma. What we have to do is we have to categorize it further histologically and apply INPC classification, and also more importantly, we save the tissue for further molecular testing, anemic being the most important of all. Okay, so although I said that we do apply immunohistochemistry to all malignant round cell tumors, neuroblastoma is one resounding exception where we do not do immunohistochemistry and save the tissue for molecular testing because the tissue cores are exceedingly small. So a little bit about neuroblastomas. These are embryonic tumors of the sympathetic nervous system. They arise not only in the adrenal medulla but also in the extra-adrenal region. And a very peculiar thing about neuroblastoma is that they are heterogeneous group of tumors, not only clinically but also for us pathologists, morphologically and genetically. They are heterogeneous, meaning some tumors can just spontaneously regress. We would never even know that the child had neuroblastoma, or even if we know upon follow-up that child would have regressed neuroblastoma requiring no therapy. Some tumors would mature on their own, and while the others are so aggressive that they are capable of taking the child's life, irrespective of a very intensive toxic therapy of all forms. So for pathologists, we need to know what are the histologic terminologies used in the neuroblastoma. It is a huge spectrum of tumors, neuroblastic tumors, and it all depends upon what is the degree of differentiation that is seen within a given neuroplastic tumors. So it can be a Schwannian stroma poor neuroblastoma, where the ganglionic differentiation is less than 50%. When it exceeds 50%, we call it ganglioneuroblastoma. When this differentiation, when the neuroplastic differentiation is minimal, we call it ganglioneuroma, and then there is spatial variant ganglioneuroblastoma nodular type. Okay, and these, let me tell you that these are man-made distinctions within a spectrum of neuroplastic tumors, which are trying to differentiate at different pace at different locations within a given tumor. So we may not be accurate in many tumors, especially in a biopsy. We can make a mistake of categorizing this. So this classification actually is made on is to be applied to tumors which are not treated with chemotherapy, which are excised upfront, and the entire specimen is excised and adequately examined under the microscope. So you may obviously ask a question: can we apply this on small tissue cores that we usually get? The answer to this question is, in Indian scenario, very, very few patients can undergo upfront resection, and we have to do the risk stratification, historical risk stratification based on what we have. It is not optimal, not ideal, but it is the reality that we have to practice in our everyday histopathology diagnosis. So again, for the classification of Schwannian stroma or neuroblastoma, we have undifferentiated neuroblastoma, where there is absolutely no ganglioglial differentiation. At this point in time, I'll tell you why was it easy for us to diagnose neuroblastoma here, because the neuroglial tissue was there. Just remove this neuroglial tissue from this picture, and what do you get? You get just a sea of malignant round cells, and obviously the clinical picture of a suprarenal tumor. And when you do not have any evidence of maturation, it becomes an undifferentiated neuroblastoma. When a differentiation starts coming in, it is poorly differentiated, but it should be 5% or less. And when it is between 5 to 50%, it becomes a differentiated stroma poor neuroblastoma. So this in itself is a very vast topic. I'll just show you how undifferentiated neuroblastoma looks like. So I have removed all the neuropil that was there in the earlier picture. Okay, just magically I extracted all those neuropils and see how this tumor has started to look like. Are you comfortable calling this neuroblastoma? Even if I tell you it's a suprarenal tumor? Why is it not a Wilms tumor? Why is it not a lymphoma? Why is it not a rhabdomyosarcoma? They all can happen at that site. So the answer is that yes, they can be any of those. And when it is an undifferentiated neuroblastoma showing no neuroglial differentiation, it is mandatory to do immunohistochemistry. So this is one exception to what I said earlier, that you do require IHCs in undifferentiated neuroblastomas. But when it comes to poorly differentiated neuroblastoma, it is still stoma poor. And now, again, I don't know how much time I should be spending on this. But what do you exactly mean when we are talking about stoma? Is this neuroglial tissue? Are we talking about this when they say stoma poor or stoma rich? What are we talking about? Are these synonyms? They are not. When we are talking about stoma, we are talking about onion stoma. That means they are spin-shaped cells, spin-shaped proliferation. And the ganglioglial, meaning this is the neuroglial tissue, as you correctly said earlier, fibrillary matrix. Okay, and these are the ganglia cells. So these are the signs of differentiation. And when we talk about stoma, it is the Schwannian stoma, which looks very different than the glial tissue. Fine. Any comments on the neuroblastic tumors here from you?
Yeah, so just to tell that if you do find a diagnostic dilemma, which is not uncommon, it's okay in an adrenal tumor, but if you get in other sites, they're from neck all the way to the pelvis, and if you're having a diagnostic dilemma, you can use ancillary investigation. So you can go back to the people, the treating team, and ask them, do you want to do an MIBG or a urine BMA, which in about 70% of neuroblastoma will be positive and help you to actually come to a diagnosis. So sometimes we may need to do that. And of course, staging and molecular testing for NMIC is critical because it changes the whole spectrum of disease, neuroblastoma. So the high risk neuroblastoma, which are stage 4 and NMIC amplified, actually are a completely different clinical behavior than all the rest of the neuroblastomas. So that high risk is actually one half of the cases we see, and very different from the rest. So that's all I would like to say. This.
Okay, thank you, Girish. Thank you so much. So we are moving towards another group of tumors. And before we go ahead, Sumit, we have time till 8:30, right? Is Sumit listening?
Yes, ma'am, we can see
Yeah,
Please continue. Yeah, continue, please.
Okay, ma'am. So, so I think I should be able to, let's see. This is case 6. This is a 14-year-old boy, and he has a very large tumor involving the lower end of the femoral bone, and which also is showing a huge extra-osseous component on this PET scan. So it's involving the bone as well as the extra-osseous tissue in a 14-year-old boy. And now this is how the tumor is looking. Who can take this case? Quickly, any volunteers?
Ma'am,
Can I describe?
Please just go ahead. Please go ahead. Please pardon me if I don't take your name. I don't know who is talking. But please go ahead and describe this tumor.
So we are seeing a photo graph which is showing us a tumor with cohesive cells around blue cell tumor with round to oval hypochromatic cells with scanty cytoplasm, and we're also seeing pseudo which are consistent with the hormone rosette.
Fine, Teresia. There is some more image of the same case. What can you see here?
So in here I'm seeing a nest again it's a tumor with consists of small round blue cells supported by thin to thick fibrous strands, and at this point I'm also seeing a formation of pseudo results which are consistent with hormone rosettes. Some blood
Okay,
is also seen in the photomicrograph.
Right. Okay. So now this is a 14-year-old boy with a tumor which lies in the bone as well as in the extraosseous soft tissues. And it is, do we all agree that this is a round cell tumor? Does anybody think that this is an osteosarcoma? Is there anybody who thinks that this is an osteosarcoma? Do we all agree that this is a round cell tumor, malignant round cell tumor, embryonal tumor, where the cells are very monomorphous in this case, and they definitely have an aggregation in our rosetoid formations. It can be a neuroglial tissue, a little bit of it. It's not very pronounced as it was in the earlier neuroblastoma, but the pattern is definitely that of a rosette formation. Definitely, yes. So in given clinical context, Teresia, can you give your thoughts about the differential diagnosis? What is possible in a 14-year-old?
From the images you showed us and from the location of the tumor, the images, I think the X-ray and the you showed us and the location of the tumor in the patient, I would think the first picture would be in sarcoma.
Okay,
That would be the differential.
That's correct. So I've chosen this case deliberately to compare it with the neuroblastoma that we saw earlier. Okay, so this is also a rosette forming tumor, but a completely different clinical context, a completely different age group, different site, but morphologically very, very similar. But see, the differential diagnosis changes. Now, at this point in time, if I tell you that this was a 1-year-old with suprarenal mass, what would be your differential diagnosis? A neuroblastoma, right? So this is how the clinical context changes everything. But at this point, let me also tell you that this is not a common morphology of Ewing sarcoma. This rosetoid, such pronounced rosetoid formations are an exception than the rule in Ewing sarcoma. Ewing sarcoma are more, uniform, very, very uniform monotonous round cells, which resemble the monotony that you get in a lymphoma. So in a bone, at any given point of time, if you're thinking of Ewing sarcoma, always think about lymphoma as well. So now, can you suggest immunohistochemistry in this case, Teresia?
CD99 will be considered also Ewing sarcomas. CD99.
CD99. Okay.
Why mention?
Why would you like to do that? How it's going to contribute?
So they say it is usually very positive in most of the Ewing sarcomas, like up to 95% of them are positive. So it will tell me that it's Ewing sarcoma.
I can't hear you properly. I could hear about the MIC2. Any specific immunohistochemistry anybody knows that is positive? In
Another one can be NKX2.
Yeah.
NKX2 is very specific for Ewing sarcoma.
Correct. NKX 2.2. That's the correct whole name.
Apella.
FLI1. Yes, we used to do it before we had NKX 2.2. We have stopped doing that. It is rather a non-specific marker. So we did have NKX 2.2 nicely positive in tumor cell nuclei, and MYC2 is a cytoplasmic membranous staining. It should be a good membrane staining for MYC2 to be positive. FLI1 is again a nuclear positivity. So this was indeed Ewing sarcoma. Okay. So 1 or 2 points again I want to reiterate about Ewing sarcoma is that always think about lymphoma when you're talking about Ewing sarcoma. You have to add lymphoma markers at least 1 or 2 in a panel of immunohistochemistry. And rosette formation is not a very common phenotype. So it is a prototype of small round cell tumor. It occurs in children and young adults. It can affect bones as well as in the soft tissues. And this is the differential diagnosis of Ewing sarcoma. It can happen in also very young children. So apart from lymphoma, sometimes a neuroblastoma, especially a metastatic neuroblastoma in the bone, then poorly differentiated synovial sarcoma also can resemble Ewing sarcoma, and then the other round cell tumor. So you have to use the good and appropriate panel of immunohistochemistry when it comes to diagnosis of Ewing sarcoma. Okay. We'll move to case 7 now.
Mukta, can I just add one thing over here? That a lot of people don't have things like NKX 2.2. It's very specific, of course.
Yeah.
Not just for Ewings. It can be also in a few other tumors. But a lot of people use CD99, that is MYC2. But apart from Ewings, many lymphomas are positive, particularly the blastic lymphomas. And therefore, nobody should use CD99 as a marker just for Ewing sarcoma.
Yeah.
It's very, very dicey to do that.
Yeah.
Without using LCA or some other marker of lymphoma, because CD99 is a very non-specific marker. Sure, I mean, you saw it in synovial sarcoma. You've in so many other tumors, and almost any kind of lymphoma can be CD99 positive.
Absolutely. I mean, we have actually years ago, I still remember, and that is why I said at least 1 or 2 lymphoma markers. That's because so many of the blastic lymphomas, they can also be negative for LCA. And I still remember one case of an extremity bone tumor, which is called Ewing sarcoma, LCA negative. But thankfully, a repeat biopsy was performed, and it was positive for CD10, and we applied more lymphoma markers. So when I'm saying differential diagnosis of lymphoma, if you have the facility, add at least 2 lymphoma markers, not just LCA. And yes, absolutely, MYC2 is a very non-specific marker. So I will be coming to this point again later. And that is what So let us move ahead. Case 7, 14-year-old boy intraperitoneal masses with ascites. Who is going to take this case? I think this should be my last case because I have some closing slides as well.
Ma'am, I can explain.
Yes, anybody, yes.
Ma'am, section shows islands on the nest of small blue round cells. Individual cells are small to medium in size and having round shape of hyperchromatic nuclei and a scanty amount of cytoplasm. Stroma appears desmoplastic surrounding the islands of the tumor cells.
Okay, and how are the tumor cells here? This is how the larger picture or the higher map looks like. What is the intervening tissue like? Do you think this is neuroglial tissue as we saw in neuroblastoma?
Fibrous.
More of fibrous cells. It is more dense than the neuroglial tissue that we saw. And these are the tumor cells. What would you call them? How are they? Is there any sign of differentiation of any sort? Meaning in rhabdomyosarcoma we saw rhabdomyoplastic differentiation. In neuroblastoma we saw rosettes with neuroglial tissue. Do you see any of this here? But they are. Do you agree? They are malignant round cells. Okay. So this striking feature is it is the low power pattern of what? A nested pattern, right? It's a nested pattern formed by fibrous band with the cells which are lying in those nests are malignant round cells without any differentiation. Some other areas of the same tumor cells around, they do have some cytoplasm which is clear. Some are spindly cells, but some do have round nuclei. What are your differential diagnoses?
Desmoplastic small blue round cell tumor.
Okay, agree. Does it fit in the clinical picture? Does your differential diagnosis fit in the clinical picture given? Peritoneal masses?
Yes, ma'am.
And a 14-year-old?
Yes, ma'am.
Yeah, okay.
15 and 55 is fine.
Right. So what immunohistochemistry would you do?
Ma'am, cytoplastic.
GFAP.
No. So see, that clinical picture is very important. Secondly, that nested pattern is very important. In a small biopsy, sometimes you may lose all that pattern. Okay, but it is an extremely important clinching point towards this diagnosis. And the third clinching point is what? Immunohistochemistry. And what is peculiar about immunohistochemistry in this tumor?
WT.
Multi-immunophenotype. That means it shows positivity for multiple lineages. Like this is A1, A3. What lineage is this showing? Epithelial. Okay, and this is also showing desmin positivity. We just saw desmin positivity in rhabdomyosarcoma. Okay, and this is synaptophysin. This is a neural marker. So this one single tumor is expressing epithelial marker, neural marker, and the muscle marker. So this is a immunopolyphenotypic tumor in an abdomen peritoneal cavity showing a characteristic nesting pattern, and this completes the diagnosis of desmoplastic small round cell tumor. Okay, I think we should skip this. This is a Wilms tumor, just to show you that the round cell tumors can also have teratoid features. But we'll skip this, and I will just go to last few of my closing slides. Before that, Girish, do you want to make any comment?
Yeah, just once that in an Ewing sarcoma, a lot of clinicians will ask you for a break apart probe for EWS-R1 or a EWS-FLI1 PCR, which many of them will ask. If you are sure about the diagnosis, finding out the EWS-FLI1 or an EWS-R1 break apart probe has no clinical benefit if you're sure about the diagnosis of Ewing sarcoma. So, but many clinicians tend to ask that to tell you want to confirm the diagnosis. But if you're sure that it's an Ewing sarcoma, and especially if you're on NKX 2.2, you can tell them there is no added value of doing that, especially clinical radiologically. logically, and it has no prognostic value either. Whereas with a rhabdomyosarcoma and a neuroblastoma, the other round cell tumors which we discussed, doing fusion testing for PAX3, PAX7, SCHR, and neuroblastoma and MIC has critical clinical value for both prognostication, for treatment, etc. Whereas here, if you're sure, it is only diagnostic value, EWS5. So if you already are sure if you're diagnosed with pathologist, there is no need to ask for it.
Yes, thank you so much. So coming back to where we actually began, the basic morphology, which is good old hematoxylin and eosine stain, still forms the basis of our diagnosis. The first and the important step is to recognize that it is a malignant round cell tumor based on what the features we just discussed. Then a malignant round cell tumor, although we define them by saying that they are embryonal and differentiated tumors, most of them do have certain morphologic features which give you a clue about their diagnosis when you combine them with the clinical presentation. There are, so these are the 4 diagnostic pillars that we are revisiting now. Morphologically, we just saw that not all are really round cells, and it's important to recognize several subtypes of one given entity, for example, in rhabdomyosarcoma or in the morphologic spectrum of a neuroblastoma. Then we should know the newer subtypes and molecular basis of certain tumors like neuroblastoma, Ewing sarcoma, and then not all embryonic tumors are round. We do have certain variations in the morphologies. We do have teratoid round cell tumors as well. And a diagnosis is really possible on a basic H&E staining in the context of given clinical information based upon certain robust morphologic features, and it decides, the H&E decides which immunohistochemistry and molecular testing is to be done. And at this point, I will also tell you that although immunohistochemistry is mandatory in the diagnosis, please, in some emergency clinical situations like the patient with Burkitt's lymphoma, T lymphoblastic lymphomas with SVC syndrome, tumors which are having impending neurological crisis, please do not shy away to give a diagnosis. You can actually make a diagnosis of a given tumor being a lymphoma or no, and that is also a very critical diagnosis to be given only on hematoxylin and eosine stain. Right? So the problems
if you can just add that, so in these emergency situations, all you need to tell them is a hematolymphoid malignancy or not. Then there are 2 broad areas of therapy we will start off in that emergency situation.
Right. Correct. Yeah. And it is possible for us, even on the frozen section, it is possible to say whether the given tumor is hematolymphoid or not, and you should make all efforts to make that distinction at least. Now, the problems in the embryonal diagnosis of embryonal tumors are, we have just highlighted that. I will just touch upon immunohistochemistry, although it forms a huge and the most important part in the diagnosis of round cell tumors, but we don't have time. So I will just say what immunohistochemistry means in this diagnosis. Immunohistochemistry detects different antigens or proteins in different parts of a cell, be it in the membrane, be it in the cytoplasm or the nucleus, by binding it to its respective antibody. And it is, as we just saw in some slides earlier, it is seen as a brown stain in the conventional tissue sections. And here we are very well aware of immunohistochemistry profiles of certain malignant round cell tumors. We just discussed all these cases just now. Desmoplastic small round cell tumor showing immunophenotypic morphology, rhabdomyosarcoma with desmin, myelin, myogenin, lymphoma, Ewing sarcoma, and case 2.2. So these are very specific immunohistochemistry profiles. But do we do all immunohistochemistry? No, we have to use the IHC panel based on clinical context and basic morphology. So in my usual everyday practice, desmin, myogenin, or myod1, any one of them, MIC2 and case 2.2, LCA, plus minus CD10 or TD3, and then I add or expand my panel based upon the clinical presentation. So I may even A3, CD10, WT1, synaptophysin as every case dictates. But this is the basic panel that I use. Now coming to the problems in IHCs, as Madam has correctly and very, very pertinently pointed out some time ago, is that the non-specificity, it's not non-specificity, it is sharing the common immunoprofile between the groups of malignant round cell tumors. Look at desmin. Desmin is expressed in rhabdomyosarcoma, it's positive in DSRCT, and it is also positive in Wilms tumor, especially when treated with chemotherapy or even otherwise, because it does have a very conspicuous rhabdomyosarctic differentiation in many instances. Now MIC2, such a non-specific marker, positive in lymphomas, positive or maybe also positive in rhabdomyosarcomas, DSRCT, Wilms tumor, and this becomes such a non-specific finding, and which makes us add the other relevant immunohistochemistry markers. So again, this chart is again IHC pitfall, the overlap of immunohistochemistries. Okay, MIC2 is expressed in so many, desmin expressed in so many. So unless you tie everything together, the clinical picture, the morphology, and the appropriate immunohistochemistry, you will not arrive at a correct diagnosis. You might miss. Okay, and now even after all this exercise, there are some tumors which might not just give you an answer based upon only these 3 pillars, and you have to resort to the 4th pillar, which is molecular techniques. And so you have to delve deeper into the C to go at the genetic level for diagnostic purpose, and then it has other implications as well. So of course, today I'm not going to go into the deeper aspects of molecular testing, but broadly speaking, it has diagnostic, prognostic, and predictive value. So I think I should stop here.
There is one question which I want to say, which I think is a good question, which is why we are calling these tumors as primitive when these tumors are showing differentiation, like rhabdomyosarcoma showing muscle differentiation, so on and so forth. So this is in the chat.
Right. Yes. So the answer is that not all tumors will show them. And there are so many instances that you will not have any differentiation at all. So you would have to definitely resort to immunohistochemistry to delineate the cell type. And secondly, even if you have, it is a very good practice to confirm your diagnosis by immunohistochemistry with certain exceptions. Like I said, in stoma for differentiating or poorly differentiated neuroblastoma, it is okay if you do not do IHCs. In fact, I strongly discourage you to do IHCs because you are wasting your tissue. But others, you might have very, very little differentiation somewhere that might be a clue to the diagnosis, but for confirmation, you have to have immunohistochemistry. And I didn't get the question very correctly, but as I always say, malignant embryonal tumors is a correct terminology rather than saying malignant undifferentiated round cell tumors, because they are not all round and they are not all undifferentiated all the time.
Thanks. Are there any other burning questions anybody wants to ask?
Girish, I would like you to address something, if you don't mind. You know, as a treating physician who treats a lot of these tumors, which a lot of them occur in the pediatric age group, would you ever treat a tumor that didn't have immunohistochemistry?
yes, ma'am, we do that. Right?
Except as an emergency.
Yeah, no, it's only as an emergency. The first cycle of chemotherapy we would give, pending the full report to come back. The common scenarios are you have a parametrial head and neck rhabdomyosarcoma, which is rapidly growing, and we just know it's a round cell tumor. So we would take a call between radiology and clinically and tell that this may be an RMS, so let's give the first cycle of chemotherapy in that basis. But in a cold tumor, if it is a round cell tumor and even without IHC and outside diagnosis has been written as most likely Ewing sarcoma, and if we cannot recruit block and treatment has already started, we would carry on till the surgery. So there are situations where we would treat without the immunohistochemistry. Definitely neuroblastoma, we treat many without the immunohistochemistry is coming. But most of the others in present day, I think people would want to, but because of pain symptoms, we would start off the first cycle pending the final report.
Yes, and that's something that I think all pathologists should know. But at the same time, I think that this is these round cell tumors. If you get the right diagnosis, I think you have gone that extra mile. So I don't think that the message should go out that you can go back to the days when you just said round cell tumor and the treatment could start and perhaps even continue. So I think it's important for them to know that maybe yes, neuroblastoma, maybe yes, when you have a emergency situation, or sometimes for bone tumors when you can't get the block and you don't want to go back. But would you say, Girish, that you should try as hard as you can possibly do to actually get an accurate diagnosis?
Absolutely, man. There is no question about that. There are only situations where it's a clinical call for there's an urgency to do treatment, and it's always on the first cycle. And before the second cycle, we would want the complete diagnosis and an accurate diagnosis. It is very rare for us to not have a diagnosis before the second cycle. And even the first cycle, we would give only an emergency. But nowadays, I think we would not go without a complete diagnosis.
All right. So that brings me to the next thing: is if you had to repeat a biopsy, would you repeat a biopsy knowing that it is a child, and sometimes it's difficult to get biopsies in children, particularly if they're deep-seated or something of this sort. How important is it to repeat a biopsy or to get an accurate diagnosis?
So it is critical, and we do it very frequently, especially when tissue is inadequate or we can't do an IHC at all. And the beginning itself, the pathology department comes and tells us there's hardly any tissue. Then we would definitely repeat a biopsy. Even the outside diagnosis may be a round cell tumor, we would definitely repeat a biopsy for the reason that the treatment subsequently is very different. So, for example, if it is a Ewing sarcoma of the soft tissue versus rhabdomyosarcoma of the soft tissue, the drugs are completely different. The staging and prognosis, what happens, are completely different. Similarly, paraspinal neuroblastoma versus a rhabdomyosarcoma, or the treatment would be completely different. So, for that reason, both systemic therapy as well as local treatment approach is very different in both of them. So, for example, in neuroblastoma, you don't need clear margins. You get a near total resection, 90%, 80% is good enough in a good neuroblastoma. Whereas in a rhabdomyosarcoma, you would never go in if you can't get a clear margin. So, the whole approach surgically and chemotherapy drugs which are used, the dose of radiation and when we do radiation is all totally different. So, from that point of view, accurate diagnosis, it goes that should be plan A, plan B, plan C should be an accurate diagnosis. If required, even to a quick biopsy.
Thank you, Girish. That's very important, and I think that makes it clear to lots of people, because it's not just postgraduates who are listening into this. There are a lot of practicing pathologists who are also listening to this, and I think that's extremely important to know. The other question I wanted to ask you, Girish, is which are those round cell tumors that you think would be treated upfront by surgery? Because by and large, round cell tumors are treated upfront by chemotherapy. Are there any that you would say would be treated upfront by surgery?
If you had an embryonal rhabdomyosarcoma which was fully excised upfront, so you've done a biopsy and you know it's an embryonal rhabdomyosarcoma, then you've done a staging and found that it's not metastatic, then you would go with upfront surgery. And the reason we would do upfront surgery is you get clear margins with upfront surgery, then it becomes a good risk disease if it is embryonal and subsequently fusion negative as well, and does not require radiation and requires very little chemotherapy in that situation. The next situation would be a neuroblastoma. If you have a localized neuroblastoma and it is not metastatic at all, then in that case you can go into upfront surgery in that situation too, and then subsequently wait for the endemic to come, because if it is non-metastatic, you fully excised and endemic is negative, then that's all the treatment that is required for a localized neuroblastoma in majority of cases. So there are situations where we would do upfront surgery. If you had a Ewing sarcoma of a digit, then many times if you're doing biopsy, we would do an upfront reamputation, because then that's a local treatment which will be done subsequently anyway, and we will do that and then subsequently go on to do the rest of the treatment after that. So, and of course in Wilms tumor, if Wilms tumor is upfront operable, which we didn't discuss much Wilms tumor today, if there are some radiological signs on which we would actually not do an upfront resection, which would be the tumor is crossing the midline, if it has gone into the inferior vena cava, if it is obviously metastatic, or if there's rupture, etc. If none of those features are there, then we would do an upfront Wilms tumor resection even without a biopsy. And then if it comes as Wilms tumor and we know the accurate staging, pathological staging, then we would go forward. So there are about 4 or 5 situations in suspected round cell tumor on radiology or we get a biopsy round cell tumor where we would do upfront surgery. But majority of them would need adjuvant chemotherapy.
Yeah, so the question therefore is, Girish, that much of our round cell tumor diagnosis now is going to be made on needle core biopsies. There is very little that we're going to do on open biopsies or getting out the whole specimen, and this is becoming more and more challenging because it depends on good radiology, it depends on a good operator to get you good tissue, etc. So what would you say, Girish? Are you happy with the diagnosis? And I will ask Mukta this as well, because you're not going to get big tissues. What would you recommend? Are you happy with a needle aspiration, or would you want a needle core biopsy?
So from the clinical side, we have never asked for a needle aspiration for any tumor in the tumor for 2 reasons. One is that you need to know the morphology, and the second component is we have to do many times molecular testing and IHC as well, so the tissue may not be. Some centers have kind of gone further ahead and done more FNACs and diagnosis on that rather than doing biopsy. So our practice, and we would recommend that we do the core needle biopsy and not actually do a fine needle aspiration cytology at all.
Thank you. Mukta, would you agree with that? Because you are going to achieve diagnosis.
Correct. I mean, it's a strict zone of organization. Yeah. Am I audible?
No, ma'am, just a minute.
Am I audible?
Ma'am,
Can you hear me, ma'am?
Dr. Bojas, I'm not able to hear as well. Please. Ma'am, you can speak now, Dr. Bojas.
Can you hear me now?
Yeah, Mukta, we can hear.
Can you hear me? Okay, it looks like I'm audible only when I'm sharing my screen. Well, Girish, and the students who are listening, it is a big no to FNAC or aspiration when it comes to diagnosis of round cell tumors. There are so many reasons. There is no advantage of having any FNAC. You cannot have your morphology. As I just said, so much of information is gathered based on morphology of round cell tumors. And immunohistochemistry, you have to do it any which way. So it is a waste of time to do FNAC, then do the cell block and do immunohistochemistry on the cell block, and in the process lose your morphology, lose the pattern. It just doesn't make any point. It doesn't make any sense. So FNAC is a strict no for the basic diagnosis of malignant round cell tumors.
Yes, I mean, Mukta, and I think this is true of lymphomas as well. So I know that sometimes it's tempting to do a needle aspiration cytology because you can don't have to use these expensive needles and all sorts of other things. But I think it is expensive in the long run because one has to understand that these tumors require an accurate diagnosis and they also require very expensive chemotherapy in the long run. And if you've got the wrong diagnosis, then this patient has lost his or her chance for a good survival and also wasted a lot of time, energy, and money on the wrong kind of treatment. So
also, ma'am, many times if the clinical response is not as expected, we go back to the block and want to review that as well. So I think having a TrueCut biopsy is very critical.
Absolutely, because you get material for archiving. I think archival material is invaluable, particularly when you have for any kind of tumor, but for round cell tumors in general, it's important because you can always go back, redo your immunohistochemistry and morphology, and also redo molecular if you need to do that. Are there any other questions? I think we've had a very good discussion. Thank you, Mukta. That's unfortunately we can't see you and hear you at the same time, but but if you can put on your video now, at least we can see you smiling because I think you really did a very good job.
I can do that.
Have lots of kudos in the chat box. So thank you very much, Mukta, and thank you, Girish, because you put it all into a clinical perspective, which